know, Care Indeed has done a partnership with the Parkinson Society, and they send us all of these wonderful materials, the pins that we'll explain, the tulip. There's a bunch of flyers that they sent us that I put out on the table, and included in those flyers are fall prevention, support for families, all the different support services that are available, signs and symptoms, motor functions, loss of motor function, cognitive changes that can help not only our caregivers, but us as well. So for you ACCMs, what's going to be really important is that you identify all your Parkinson's clients and those clients that have Parkinsonian-like symptoms. Okay, and we're going to do spot surveys, and I have a handout on how we can conduct those spot surveys. And again, this isn't my design, this was put out by the Parkinson's Society, what they recommend. As far as medications and things in the home and how to alert our caregivers that they have Parkinson's, and hopefully specialized training for those caregivers that help them develop the care model. Who am I? You know, my name is Lori. I like the slide D. I'm an LVN. I'm also a mentor, educator, and trainer. And one of our learning objectives for starting out is that we understand Parkinson's disease. Okay, we identify the stages of Parkinson's disease. Why would you just think briefly, why is that important that why we identify, like say first stage, second stage? What would be meaningful for us in that? What would be the takeaway? Raina?
Just so we can meet their needs where they're at right now. And
right. And different stages, as we know with dementia and other types of disease processes, we have certain cues, certain things that happen in different stages, which can alert us as caregivers and care professionals of how we can problem solve ahead of time, say when they start to become a fall risk, and what interventions we have to have in place to prevent injury and make that progression smooth as we can throughout their activities of daily living. We'll have a comprehensive system overview, different care and support opportunities and strategies, supporting family as well as the caregivers. We have a Parkinson's toolkit where we have a lot of different devices that can simulate what a PD client has when they're trying to ambulate, when they're trying to eat, and they have symptoms of tremors and freezing and rigidity and those types of things. So these things will kind of simulate what they go through. We have symbols of hope and support and resilience, which is your tulip that you're wearing, and key takeaways at the end. So you can ask questions as we move forward. Okay, and if anything is unclear, just let me know. So what is Parkinson's disease? Does anybody know? What's the first thing, very basic, that you think of when you have a client with Parkinson's? Tremors. Tremors is the first thing you think of, right? But it's really so much more than that. Okay, Parkinson's is a neurological disorder. Okay, so we have these neurons. Say this is a nerve cell. Okay? And this is the axon, this is the conductor. If we go and we plug in, we're plugging myself into this charger, right? But the cord maybe is damaged, or your cat or dog chewed on it a little bit, and the conduction isn't as good as it normally would be. What happens when I'm charging? It doesn't charge, but at first, maybe it's just a little bit kinked and I need to straighten it out. So it's still charging, it's still getting a signal, but it's not as effective. And then pretty soon, if I keep using that same charger and I'm cheap and I don't go out and buy a new one, it's not going to make a conduction at all, right? And that's what's kind of happening with Parkinson's. It's a progressive, insidious disorder that happens slowly. And it turns into, you know, greater than just a tremor. So neurological means what's happening in the brain. Right. So these nerve cells that are in our brain that occupy a very small part of our brain. It's called the substantia nigra, and it's kind of in the midbrain. And that's what's responsible for releasing dopamine. And you probably kind of know when we get dopamine, like when we're exercising, we'll get dopamine. It makes us feel good, right? It helps regulate our mood, as we know, and all other things. Feeling like when you're with a person for the first time, you're going through that honeymoon phase and you get that surge of, those pleasure receptors, that's dopamine. Well, what's happening in Parkinson's is over a period of time, those nerve cells don't produce dopamine anymore. At first, it's very sluggish, and then it gets to be a great loss. And then what happens is we lose fine motor functions. What are some of the other things you see? Loss of balance, right? The ability to control fine motor skills. And then on the part that we don't see, depression, loss of identity and self. We can't express our emotions, right? We don't feel emotions or pleasure the same way that we used to because those chemicals are not there or affected. And so the primary functions of dopamine, again, are to coordinate smooth muscle movement, and mainly inside of that basal ganglion. It regulates our pleasure receptors, our reward systems, our level of motivation, and our cognitive function. It supports our attention span, memory, the ability to problem solve, the ability to process information, which is why we've always said in the past you need to slow down. And you'll hear V say this even with dementia. When you're giving step-by-step instructions, you need to slow it down and be very specific because they're not being able to regulate and support that. The first stage of Parkinson's, you might see just a mild tremor, and usually it's just on one side. Like you'll see a person walking and maybe their hand will just be kind of twitching. Okay. The second stage, you'll see motor tremors, both hands, both extremities might shake. So at first you might see a person that's walking and they're just like this, and then pretty soon they're like this, right? They're moving both hands. Or they're sitting and they start doing what's called pill rolling, where they'll be sitting and it's very distinct. They start getting a forward lean and they go like this with their hands. They rock and they move their front. That's why they call it pill rolling. It's very specific, okay, to this disease. Does everybody do it? No. Do they move through the stages differently? Yes, they do. In stage 3 is probably the most significant because this is where we start seeing balance issues. So what does that tell us as that we need to inform our caregivers about? What's significant about having a balance issue? They're going to fall, right? And coincidentally, one of the handouts is fall prevention. So you're going to see a change in walking, in posture, and in balance. So first, when you see a person with a steady gait, the gait meaning how they walk, they're picking up their feet, they're walking, right? Moving along like this. Person that's more developed, what happens is they lose that arm swing. Their hands stay straight at their side. They have a forward lean. Their gait is short and shuffled. And then they shake. So you can see in this body position, my base of support is totally off. My legs are close together. I'm hunched over. I might have a tremor. My elbows are bent and I'm tremoring. And then they say, well, give them a walker. How am I going to use a walker? Right. So my whole base of support is thrown off. We have to be able to communicate with the caregivers how we can support that person. It's not just give them a walker. They're going to have support in using that walker. They're going to require cues on how to pick up their feet. And some of the things that we have on the table will demonstrate the challenges with that. Question. What happens to dopamine producing neurons in Parkinson's disease? What happens to them? Do they produce too much dopamine? Are they lost or do they die? How many said A, B, C, or D? B, they die. We know that nerve cells do not grow back. They cannot repair themselves. Once they're damaged and gone, that's it, right? So in stage 1, we have mild tremors, usually one side. Stage 2, you'll have a combination of the two. The person is still independent of ADLs. Even though there might be some tremors, there might be a loss of smell, loss of taste. Those insidious things are happening. But for the most part, they're pretty much fully independent and can function with their own ADL care and that sort of thing. Balance issues might start to appear in stage 2 as they progress into stage 3. They're mostly independent, but they might have some challenges. Some of those challenges, again, because it affects fine motor skills, is maybe cutting their food. They have a steak or something, they need help cutting that. They don't have that dexterity to do that, but they're still able to pick up the utensil and feed themselves. But now, as we progress, maybe they have difficulty shaving. They have difficulty buttoning a shirt or zipping up a zipper. Again, because it takes fine muscle coordination, the smooth muscle tissues, right? So they might need assistance in those early stages. So stage 3, again, we start seeing balance problems and we start seeing fall risks showing up on our care plans. With that being said, the ACCMs, myself, anybody who's taking care of these clients that are in the care plans really need to, it's expected that this is going to happen. And you should see support needs. Do they use a cane? Do they use a walking stick? Do they use a walker? What extra support do they have? Do they have, does their caregiver use a gait belt? You know, we start thinking about all those support systems. Supervised movement. This is going to require standby assistance of a caregiver in and out of a shower, walking to activities, walking in the neighborhood where they're not picking up their feet and they're tripping on pavement. This is what the caregiver needs to be alerted to if they are standby assist for safety and mobility, right? Stage 4, this is where we start seeing severe motor impairment. Many people can become absolutely immobile at this time where they're not even able to stand. They might be starting to be more bed-bound, wheelchair-bound. They start having a flat affect, meaning they don't show any facial expression. Earlier on, their voice starts getting softer, kind of starts disappearing where you really have to listen. Their speech might even be delayed. So it's important for a caregiver, and I've experienced this on assessments where I was speaking to a client that's got advanced Parkinson's, and they can speak, but they speak very soft, so you have to get closer to them. And their speech is often delayed. They're searching for the right word, how to express themselves. And again, facially, you're not seeing, you know, they're smiling, or often they're even drooling. They don't have control of their secretions, oral secretions. And sometimes they'll even stuff things in their mouth because of the drooling. It's embarrassing. So you have to listen very intently. And as they're searching for a word to communicate with you, because you've asked them a question, you can't go, oh, you mean you have trouble standing? You need to stop, ask them a question, and wait. And it seems like a real uncomfortable pause, but they get it out. You need to give them the opportunity to do that instead of just taking over. And some of my longer assessments have been because of that, because I'm speaking with the client, and it's not unusual for a spouse or a significant other to go, oh, Lori, he does, and they'll speak for them. Okay? You're communicating with them. They're there. They're just having trouble getting out and communicating this to you, what you've asked them. So it's really, really important not to rush them, to not awkwardly wait for their response, right? But just wait, and then you can go on from there. Okay. For the clients that are bedridden, you're going to see an advancement where they might stop eating, they might stop drinking, they're choking when they're eating or drinking. Maybe they're aspirating, they're getting secondary diagnoses of UTIs, of aspiration pneumonias. You know, the list goes on and on. Complications that any bedbound client, anybody with decreased mobility would have. Constipation. So you're having mobility issues, which kick off constipation issues, muscle wasting issues, right? Loss of strength in your muscles, the ability to even hydrate. Maybe it's because they can't hold the glass and drink it because they shake, or maybe because they can't swallow regular liquid food without it being altered in some way, like adding thickened fluids that makes it easier to go down, or change in diet, pureed diet, for example, or mechanical soft, those types of things. So we have to start thinking, again, this is a neurological disorder. What does your brain control? It's the computer of your entire body, right? So as systems start to fail, as that signal isn't working anymore throughout your body, you're going to see changes in all systems of the body. Okay. And then it comes down to maybe considerations for palliative care, how we can support the caregiver. So with your bedbound client, it's hydration, right? Nutritional support. It's turning and repositioning, taking care of the skin, because the skin's going to break down with the rest of the body. As you don't move or get up or move around, we're going to break down on the skin too. So we start thinking of supportive means, like with mattresses and wheelchair cushions, if they still get up. Even if the client gets up in a wheelchair, you're still upright and there's still some movement, versus laying in bed and becoming so sedentary that things stop moving and working, you know, to even bowel functions or bladder functions, right? Some of the motor systems, I described the pill rolling, Brady, kinesia, slowness of movement. So if you just take the prefix, usually Brady means slow, and then kinesia is in the act of motion. So slow movement, rigidity or freezing. So rigidity is like this: when I'm walking like this, and I'm not moving my arms, I'm stiff, I'm hunched over. And then freezing is when I'm walking and my mind is saying take the next step, but it's like I'm in quicksand and I can't get to that second. That signal is being lost in transition. So I'm going to need help with that. That's what they mean by freezing. Or a stooped and shuffling gait. And again, you're shuffling around, and what happens with the walker is they build up momentum, and then they start going so fast like this, and then they can't slow down. So a caregiver needs to be alerted to that too. Difficulty rising from a chair. Okay, so Amarita's sitting here. She's got Parkinson's. Okay, Amarita, it's time to get up now. Come on, let's go. Right? Not only did I create nerve damage under her armpit, but so what we're going to do, feet flat on the floor. Okay, Amarita, I want you to hold on to your chair here, and I want you to use your momentum. 1, 2, 3, and then I want you to get up. So 1, 2, 3. Okay, so it's a step. Gait belts would help. We do this in our training right now, remember? So, thank you. So, and at some point, you know, they are going to need a gait belt where you're in front of them and you have to get them in a standing position, and then they're good to go. So you'd have to meet them at the level that they're at, right? So that's what we mean by, you know, getting up, difficulty getting up from a chair. Let them do for themselves as much as they can. So you're looking at the deficit, the problem that they have, and you're modifying the environment to suit them, whether it be the chair they're sitting in. They need a chair with arms. They need a chair that's low enough or not too low, but the right height so that they can use that momentum to get up. So you're thinking of all those steps that you would take for yourself to your client. They also experience macrographia, which is a really cramped handwriting. And I see this when I bring the service agreement sometimes, where I just go, whoa, I can almost see that. Their writing gets really cramped, real tight, rigid, almost like the rigidness of their body, like it's almost not even legible. The masked expression, meaning no facial expression. The things you don't see. So when we started out, we talked about what do you think of when you have a Parkinson's client? You see tremors. We can see that it's really much more than that, isn't it? At a neurological level. The things that we don't see are the diminished sense of taste or smell, the low voice volume, they can't project their voice anymore, sleep disturbances. How often is your client sleeping? That's important. Okay, there are some clients that sleep a couple hours a day, and then they're taking naps throughout the day because they didn't sleep all night. So it's important for if they have caregivers and staff that they log approximately as best they can the hours of actual sleep. Depression and anxiety. So you have a person who's lost the ability to care for themselves. Maybe there were a lot of things that they found pleasurable, enjoyable, hobbies that they had, whoever they were in the community with their careers, that they can't do anymore because their hands don't work. They can't operate a computer anymore. They can't type. They can't write. Right? So you can see there's a whole lot going on here. Again, I mentioned the constipation and urinary difficulties, hallucinations. This is also common in some dementia clients, Lewy body dementia, right? So there's a lot of diagnoses that will go over into our different stages of dementia, which is why V does the training that she does, because you'll see that with Parkinson's, you'll see it with the different dementias, and even Raina brought up to me today an ALS client. There's a lot of similarities, guys, with mobility issues, the ability to work motor skills, fine motor skills, that mimic, even though they don't have a Parkinson's diagnosis, the caregivers or the people that are caring for them would operate in that same manner to care for them. Hallucinations and low blood pressure, especially when going from a sitting or a lying position to a standing position, and then they get that hypotensive reaction where they get dizzy and lightheaded and disoriented. What's a tremor? Everybody say C? You are correct. When will someone with Parkinson's need help with daily tasks like bathing and dressing? Stage 4 or 5. They say it starts in 3, but the latter stages of stage 3 in a lot of the documentation. So this is stage 4 or 5. It's right in that same area. And again, the whole reason that that's significant for us is so that we can establish a plan of care that's appropriate to the changing needs, the decline, if you will, to the client. When should you be most concerned about falls in someone with Parkinson's? B, right? When they start having balancing issues. So hopefully you can train your caregivers that, hey, maybe you've got this client with Parkinson's, but they're at a very high level of functioning and independent. Maybe they don't even, you look at them and it's like, gosh, it doesn't even look like they have Parkinson's. Hopefully that caregiver will call you and say, hey, you know, I've started seeing some balance issues. They're stumbling. I've had to catch them a couple times, sitting on the commode or getting up from the commode. Hopefully that they'll know to recognize this and to call us so that we can, you know, update their plan of care, do a visit to see what modifications or what things that we can do to keep them safe. Our experimental toolkit that we have. So we have the weighted booties that look pretty much like this. And again, that's so that you can understand the difficulties that a Parkinson's client has when lifting their feet, putting one step in front of the other, the feeling, they have Velcro on the bottom, the feeling of being frozen or stuck, right? And then the tremor stimulation spoon, so it's battery operated. Try to pick up some beans with it, turn it on, and shake. I didn't put liquids in a cup, but you'll get the point with that. So you can practice with that. There's also a lot of dexterity challenges. I have one where there's gloves, and you can pick up pennies with the gloves, and just see how those fine motor skills, you have to really pay attention to it. Okay, what should you do when somebody with Parkinson's has difficulty getting out of a chair? That's going back with Amarita. What would you do? Okay, so brilliant, they tell you. C. This is a figure that I really like. This is a key motor symptoms model, and the acronym that goes with it is tremor, rigidity, akinesia, and posture and balance. So the tremor is the shaking, the rigidity is the stiffness of the trunk or the limbs, the slow movement, the impairment of voluntary muscles. So the voluntary muscles are muscles that we do on purpose, right? My hand's going to pick up this water bottle. That's a voluntary movement. Involuntary movement is when I blink my eyes. I'm not saying to myself, blink, okay, blink, or blink again or your eyes are going to dry out, right? So these are things that we're supposed to have control over, but they don't. You'll see he has that forward lean, his base of support. His feet are very close together. His knees are bent. His elbows are bent. He might have tremors, right? He's experiencing rigidity. All these things that we talked about. This is what it looks like. This is what your client is going to look like. They're going to have that lean, and they're even going to do it in their wheelchair. So you would be particularly concerned with somebody who's in a wheelchair, who's leaning really far over, because they can topple over and hit their head, okay? So there are different wheelchairs that we can do to support somebody who's got that forward lean so they don't topple over. Know that there's different periods of the day. The reason why medications are so important and diet is so important that we'll talk about in a minute is that levodopa, a medication that commonly is given to these clients, if they have a high protein intake or they take them at different times a day, the absorption level and the time that it takes for the medication to reach its peak threshold vary. So it's just like, I know a lot of you are familiar with people that are on levothyroxine, and they have to take it before breakfast, right? So it's like, okay, 6 o'clock, you're giving them that pill so that they can eat their breakfast. This is kind of the same thing. You don't want them eating a steak meal and then give them their levodopa, right? Because it's not going to absorb as well or be as effective. It's the same as in our training when we give medications, when we see that they're more rigid at a certain time and we're not cognizant of the time or giving medication that's late. To them, it means a lot. And I've experienced this in my assessments. There was a client that I had who actually went into the hospital for levodopa toxicity. And he was at a facility, and it really messed him up for a few weeks. So he was getting more than he was supposed to get. And the reverse is true, commonly, or when it's late, and then it really messes up their routine because they can't participate in physical therapy. They're not moving as well for the caregivers. They can't stand up. Maybe it's that caregiver that says, well, I don't know what's going on. You know, Miss Samantha, he was moving yesterday. He was standing and walking with me. Now he's a 2-person assist. It might just be because he didn't get his medication. He got it late. He had improper nutrition. It could be a lot of things than to assume, hey, right now he was fine yesterday and today's a 2-person transfer. I'm just saying look at your options, that might not always be the case right away when there's a fast turnaround or there's something else going on with infection or something else that we need. Regardless, it needs a visit, right? It warrants a visit. Here are just some nutritional things. Work with the healthcare professionals. Timing does matter with proteins, again with the levodopa absorption. Monitor how different foods affect different symptoms that they have, especially foods that cause inflammation and have an inflammatory process will make them move less able. Food to limit high saturated fat foods, processed foods. Again, those processed foods can really increase inflammation. High proteins need to be watched with the medication. Hard to chew or swallow foods, cutting it up into bite-sized pieces, or giving finger foods are successful. I find that a lot of the clients, what we would do is like we'd make sandwiches and stuff for lunch, and we'd cut the crust off, come in bite-sized pieces. They could pick it up, and they'd walk with it, you know, if they didn't want to sit down, and they could manage that, and they could feel successful versus somebody feeding them or cutting up their food sitting right next to them. So lean proteins should be given, fish, meat, poultry. Adequate hydration is a must. I just want to say I don't have a tippy cup, but there are cups that have a lid on it with a little opening. You can put that on the table with special utensils that they can still use, and even though they're tremoring, they'll still be able to get the liquid and not spill all over themselves. And that's a better substitute than a caregiver going, here you go, and putting it up to their mouth. And these handouts are all available for you guys. Supporting family and caregivers. So slowness and patience is the key, I think. Allowing them to, you know, move through space, not discouraging them to move through space or walk around the house with standby assistance. To keep that movement is far more important than sitting in a chair and having a caregiver retrieve things for them. It's unpredictable. It's going to be like this, and we don't know how fast it's going to go through. They might have great days, and then they're going to have a bad day where they don't want to get up from a chair, they can't stand. That's how it is. So what the caregiver needs to do is modify their plan of care to what they're seeing at that time that day. It doesn't mean it's going to be that way tomorrow, right? And take note of it. Realize that the client is going to experience a loss of independence. They're going to feel a strain on relationships, family members, spouses who have turned into a sense like a caregiver, taken instead of a role of a husband, wife, daughter. They're now caregiver, and they're looking for our caregivers as supplemental care to give them respite. Right? Dreams, hobbies that they've had, and I heard V say this in her dementia thing, that, you know, we take care of chemists, professors, aerospace engineers. This is going to affect a person's identity, to not be able to walk across the room or feed themselves, right? So again, much more than just a tremor. Here is our symbol of a tulip. What does the tulip represent? I'm going to read this to you because I think it's important. The tulip is a symbol of hope and resilience for the Parkinson's Foundation. It represents strength, beauty, and the ability to thrive despite challenges, much like how people living with Parkinson's disease continue to show resilience in their journeys. The Foundation uses this imagery to foster awareness, support research, and promote education about Parkinson's disease, aiming to improve the quality of life for those affected by it. You each have a pin that's to remind you of our Parkinson's training and our clients that are trying to thrive and just to be aware. And there's also magnets on the table. I would like each ACCM to identify the clients that they have, as I stated in the beginning, of your clients that have Parkinson's or Parkinsonian type behaviors. Raina, I would even include your ALS in how we go about that, the care and our care plans. I would like you to take a magnet and put it on their refrigerator. Educate your caregivers that this is what that tulip represents. You know, the mindfulness of the unpredictability of their care, the safety issues that they have, in the many concerns with independence and communication, right? And just their identity is a reminder to our caregivers, and that they can reach out to you for support. So everyone's journey is, again, it's an individualized plan of care. It doesn't always follow steps 1, 2, 3, 4, 5, right? People are in different places. So as caregivers, as healthcare professionals, we need to modify our thinking in the way we do things and step out of the box. And sometimes it's really challenging to see and look at the environment and the person that you care for and come up with ways that we can modify their environment, teach their families to better cope with their daily lives. I would like now for you guys just to play around with, so these are the boots. All right, so say Kim has got Parkinson's, and Kim, your knees are bent, you've got that forward lean, your base of the feet are close together. Okay, you've got that hunched back. Generally, when Parkinson's clients walk, they don't walk like this, right? They walk like this because they're watching their feet, making them work, right? So you're saying, okay, Kim, let's go for a walk around the block. Okay, what I want you to do is stop. Separate your feet just a little bit for me.
I can't lift this up.
Okay, now I want you to put your head up. Okay, let's go. I want you to take your right foot. Now your left. Good job. Right? Left. Keep your head up. Right? Good job. Okay, so the whole point of this is that I'm giving cues. I'm expecting Kim to get stuck. I'm expecting Kim to hunch over. I'm expecting Kim to take off with his walker. I'm prepared for these things. That's why I'm sitting here. I probably would have a gait belt on him too. But you can see it's really challenging, isn't it?
Yeah.
So now throw in a hearing loss. Throw in a visual problem, which we'll commonly see, right? So Kim, pick up your right foot, right? Maybe Kim can't hear my instructions. You know, Kim's not looking at me. Kim's concerned about his feet working, and, you know, maybe he's shaking and he's afraid he's going to fall. Right? So these are all things that we have to think of. We don't just say, okay, let's go for a walk. Let's go. Come on, come on, come on. Places to go, people to see. Right? We need to slow it down. Right? Good job, Kim. So, and you guys can try this on your own if you don't want to. So Amrita, I see that you have your spoon. So I would like you have some lentils here. I want you to try to feed yourself. Put it up to your mouth. Whoops, there's none left. Go again. You got to be quick, Amrita. Quick, you can do it.
Gosh. No, I don't want to live like this.
See? Hurry up. Come on, you can do it. What's a caregiver going to do? This is what a caregiver is going to do. Okay, so Amrita, you're sitting there. Go ahead and try. Oh, just stop. Okay, just stop. That's okay.
Yeah.
Here. Come on, we have to go to a doctor's appointment. Hurry up. Whoops.
That's why.
Here, just take a finger food and let's go.
No.
Right. So even though we use finger foods, it's meant for their independence to feel successful at a meal, right? The same thing with using a tippy cup, something that they can hold and do themselves versus us taking over the whole thing and doing it, right? It's messy. They're gonna have a clothing protector on. The whole table might be, with food. Don't draw attention to that. Far better than some food. Their clothes are protected. Let them be successful. Give that to them. Don't set them up for failure. Right? You get the point, right? Okay, now our gloves. So I don't know, Alex, if these will fit you. You can try to put.
All right.
So this is, again, fine motor skills, dexterity, this would be the equivalent to putting a peg in a hole and doing these different coordination exercises. Just see how easy it is. You smarty pants.
Rena is just trying to show off.
Oops, you're shaking. Maybe the gloves need to be thicker. I think I'll bring thicker gloves next time. So you guys feel free again. This is a lot of good supportive documentation that the Alzheimer's or Parkinson's Society gave to us. We can ask for more of any of this stuff. So as it pertains to you guys, in the ACCMs, I'll give you the survey for the sites on how to do your surveys.
Thank you, Lori. Thank you, Lori.
You're welcome. Thank you.